brilliant technological advances. Oh, sorry, I'm trying to. Hey everyone, it's Jen McAndrew here. I'm just behind the scenes. We're still admitting people to the session, but just wanted to do a quick Zoom etiquette. You'll all be muted as you come into the session. You do have the ability to unmute yourself if you have any questions, but we just ask that you stay on mute just to remove any background noise for the other participants. The sessions are all being recorded, so you'll have access to that after the fact. And if there's any, the chat's also being recorded so we can share those comments with the speakers later. So thank you for being here, and I will leave it to Michael.
Thank you, Jennifer. So welcome everybody to our session, Wisdom from a Virus. I'm going to, so everybody's muted like Jennifer was saying. I'm going to ask people, we'll probably be doing some questions. So just unmute yourself. If you have a question while I'm going through something, absolutely put your hand up or even just talk out loud. We're actually a fairly small group so far. So we should be able to manage it that way. I'm going to be jumping back and forth between a presentation and in person. On in person through Zoom, if that makes any sense. And I'm going to ask as many people as are comfortable to actually show yourself on screen. A large part of this presentation is actually about connecting virtually and how do we assist our clients and how do we work in our program so that we can connect people virtually. So particularly near the beginning, there's going to be a little bit of that. And as we go into the presentation, if you want to go off screen, that actually makes a lot of sense. So I'll introduce myself first. So my name's Michael Lochran. I'm a registered psychotherapist, and I'm the Director of Programs and Operations at Renaissance Center, which celebrated 50 years last year during the pandemic in providing residential care. We have three inpatient treatment centers in Toronto and Whitby, and also family programming, children's programming, and continuing care. And when I was asked if I would like to do this presentation, my immediate thought was, this was a few months ago, future Mike would absolutely be happy to talk about COVID at a virtual conference. And as it got closer and closer to actual time, I started to notice that I started having anxiety like I would when I was doing any kind of presentation like this, but the anxiety actually seemed quite a bit different. And a lot of that focused around the fact that, when I speak, I actually like to be standing up. I like to be walking around. I like to be interacting with everybody. And most of my thoughts were around the fact of how is that going to happen? Are we going to be able to connect in this way? And the interesting thing is for the past 16 months or so, I've actually been talking quite a bit about uh, the power of virtual to actually initiate genuine connections. And we're going to be talking about a virtual program that we developed at Renaissance a little bit later. And I've actually seen this. I've seen people have real, genuine connections through virtual. But my first thought was, how is that going to work? And then as I got into the days before this presentation, I started to realize that there was some benefits to this. I could have some notes in front of me on the desk instead of like small scraps of paper in my hands as I sweat and try to read hieroglyphics that I wrote in shorthand so I can figure out what I was going to say. I've never actually used those when I'm speaking. I could be in a really comfortable climate controlled room and kind of have perfect control over the presentation, which I actually like quite a bit. So to start off, what we're going to do is we're going to level set a little bit. The next thing that I started thinking about, the topic that I was given was COVID. It literally, can you come and do a presentation on COVID? And like, after I had thought about future Mike would be happy to do that, my next thoughts were along the lines of what am I going to talk about COVID? I also had some thoughts we're going to figure out COVID in either in this presentation or before we get to July. And I'm not a doctor, regardless of how many reruns of ER I watch and what I think of myself. And I quickly eliminated talking about infection prevention and control because everybody on here for the most part is become a specialist in infection prevention and control, and I don't know that I would teach you anything new that you didn't know, and you know your own settings far better than I do. I've often had thoughts that I'm actually going to have to reteach myself long division and the rules of backgammon after COVID has subsided, just based on the information that I didn't really want that I now have. And really, what I settled down to on what we're going to talk about is we're going to talk. I wanted to include what are some things that we can do right now in our programs. What are we experiencing in our programs? What are the challenges that our clients are seeing? And how can we help the clients that we have in front of us? And are there ways that we can kind of realign our thinking when we're working with clients? And then another part of this is, the COVID-19 pandemic is such a kind of universal experience that it has put so many of us under stress. And it, events like this and experiences like this really do educate us afterwards and educate us in the way that we think, in the way that we connect, in the way that we can help people, in the way that we can organize our systems in order to better help people. And a lot of my thought has been as well about, what can we take from this to change the way that we provide care? And some of the assumptions that we have and some of the things that we know work, can we improve them and can we change them? So part of this presentation as well is going to be about maybe changing some of the systems that we have, uh, taking a look at the future, and as we build towards a new system 5-10 years from now, what should that system look like based on the experience that we've had and based on what we've learned. So the first thing that I want to do is I want to take a moment and, as I was thinking about this presentation, it was actually a little overwhelming because I was doing some research for some numbers to put on my slides, and the overwhelming impact of COVID on kind of our society, our clients, and ourselves. And I know this has been a very difficult year, and basically for everybody that is a colleague of mine, everybody that I know in this field, it has been a really difficult year for a number of reasons. And first, I want to call that out. I mean, I don't think it needs to be. I think it's something that we all know and we all feel. But then at the same time, I want to take some time and reflect on the amazing work that continues to be done under these circumstances. And that there are people who are getting clean and there are people who are changing their lives in our programs. And that our counselors are impacting people positively. And despite all of the challenges that we've had, we continue to do that. And we continue to do that in really a dramatic way. And it may not be how we would like it to be, but it still happens. And we are still changing the world in the work that we do every day. And so, what I'd like to do is, on that note, take a moment and do a little bit of a grounding exercise before we start and before I put my slides up and we can't see each other's faces. So, I'm going to ask everybody to get yourself situated and get your feet flat on the ground and feel the ground underneath your feet. And if you can, the one that I like to use is do a big hug, like hands out, and then turn your hands up to catch raindrops, and then fold them and put them on your lap. And this is the easiest way I know to end up in kind of the meditative pose. And we're just going to breathe in and breathe out and breathe in. And as we breathe, take our awareness to that center part of our chest and feel our stomach moving and feel our feet flat on the floor. Feel ourselves in the physical space that we're in right now. And now take our awareness and extend it out into the virtual space that we're in. And open our eyes and see if we can feel the presence of those on the screen with us. And feel those people that are here together, gathered to have a conversation. So, again, welcome to Wisdom from a Virus. I actually think the title of this presentation is actually a really good indicator of the effect of COVID and social isolation on myself. When I read it again, it is incredibly long and probably wouldn't have been the one that I chose. But so, like I said, the things that I'd like us to talk about, try to break this down into kind of 4 areas. And so, first, talking about social distancing, isolation, and our mental health. And this is going to cover kind of just in society, a little bit of ourselves and our clients before they come into treatment, as they're trying to access treatment. And then if there's some strategies that we can use and very quickly leverage in order to assist our clients. And a lot of this is happening in all of our programs already. And, I was hoping I could come up with something that would be kind of dramatic and new, but the understanding of how to work with people in pain and trauma is so great in our field that really a lot of this is sometimes just adapting what we're already doing. And we're going to talk a little bit about the disruption of daily life and a loss of meaning. And is sudden onset addiction occurring during the pandemic? And this is a little bit of looking at, we know what and we're going to talk a little bit about what the current impact of COVID and social isolation is on our society, particularly in those using substances. But is there another situation that is building, and what is that going to look like, and how can we cope in the future with that as a system? And we're going to talk a little bit about the limited capacity in mental health and addiction services, and how do we achieve the best possible outcomes with limited resources. And that's when I'm going to talk a little bit about the virtual program that we launched at Renaissance and a lot of the findings that came from that, because it was actually really quite interesting to myself and also to where us as an organization, but then where us as a field and a system could go in the future. So first of all, these numbers just shocked me. An estimated 6 billion people have been isolated in their homes during the pandemic. And social distancing has likely prevented 500 million cases of COVID-19. And it helps me to remember and take a look at all of these things that I really dislike, and the situation that we're in that I dislike is really there for a purpose, and it's there for a purpose that it's actually achieving. The consequences of social distancing in Ontario, just to kind of set the stage a little bit. So substance use has increased. 42% of adults report increasing their substance use or gambling during the pandemic. And overdose deaths continue to rise. And I know that this is true across North America, across Canada, and in some places in Canada, the rates are actually even higher. But in Ontario in 2019, we were averaging 197 deaths a month. 2020, 292. And in the first 5 months of 2021, 328 deaths a month, which is really just shocking and a horrible number to hear. And at the same time, our wait times for services have increased. I never would have thought that I would have wistfully and longingly thought and wished for the wait list that I had in my programs from 2019. But in inpatient treatment, our wait lists are 40%, on average, 40% longer. These are numbers from Ontario, but withdrawal management, the wait can be 71% longer. And day and evening programs by 47%. So the length of time that people are waiting for services is dramatically impacted. And I had a couple experiences last week where I was meeting with a couple members of our kind of senior leadership and clinical leadership teams. So I had 3 meetings in a row, and in each one of the meetings, first myself and then 2 of the other participants actually couldn't get something to work properly. So I actually couldn't remember the password to get into my computer when I was trying to have a meeting, and somebody else couldn't get something on their computer working as well. I got up from these meetings and actually walked into my desk as I was trying to leave my house. And I'm actually going to stop the share for a sec because I think this is really interesting. If you look behind me on the second shelf there is actually a replica of Thor's hammer from the Marvel movies. And I purchased this last week, and I was actually shopping for shorts because I didn't have any shorts. And I went upstairs and I laid down in bed and I had this thought, and I thought, did I just buy a life-size replica of a superhero's prop from a movie? I think I actually did. And every time I share this with people, they actually tell me about very similar things that they've done. And I think it's actually a fairly widely shared experience. And when we look at social isolation in the brain, there's really 3 areas that we know that first come to mind where social isolation has a really strong impact. The first is the hippocampus, and it's difficult to study social isolation's effect on humans because it's cruel to socially isolate humans to see what's going on. So you have to kind of look around for times when this happened. And, there was a study done on Antarctic expeditioners, which said that 14 months of social isolation is actually enough to physically shrink the size of the hippocampus. And the reason why that's important is, the hippocampus is a very old part of our brain. It's in our midbrain. It regulates memory. It regulates learning, spatial awareness, which I thought a little bit better about walking into my desk when I learned that there was a neurobiological reason why I may have done that. And it also has to do with learning to be able to inhibit impulses. So impulse control and learning the skills needed for impulse control, and delayed gratification actually does involve the hippocampus. So social isolation, first of all, actually has some very dramatic effects on very base level neurological functions that are related to addiction. And the mesocortical limbic system, the one that we know of most closely related to addiction, which is VTA and nucleus accumbens, are the reward system. And this is the system that drugs of abuse hijack in order to experience a high. It's also the system that reacts to mark reward and relevance in social interactions and the development of community. And it's actually been found that people in the earlier stages of social isolation feel social longing and craving. And that craving is in this system, which means that craving is actually incredibly similar, if not exactly the same, when experienced on a physiological level to cravings that we have for drugs, the cravings that we have for food, and cravings that we have for sex. And the HPA axis, which involves stress response. And we're going to talk quite a bit about stress response related to the pandemic, but this is actually just stress response related to social isolation. And in animal studies and in measurements of humans as well, they found that uh, significantly higher cortisol levels in animals and humans when they're removed from their social group for no other reason. So, not even experiencing a threat, but just the fact that we are no longer in our community is enough to trigger fairly high stress responses. So the impact on social distancing, mental health in Canada. This is an Ipsos poll, and 56% of Canadians reported feeling increased stress or anxiety during the pandemic, and 61% of the Canadians in each one of these categories, those 18 to 24 reported the highest rates. And so 61% of Canadians reported, 18 to 24 reported increased stress or anxiety. 44% overall, and 53% of 18 to 24 reported their mental health was in bad shape during winter of 2021. And 55% and 60% of 18 to 24 report social distancing has left them feeling isolated and lonely. This is important for a number of reasons, but also just in a setting building blocks for mental health. So, out of the social determinants of health, there have been three that have been identified particularly important for mental health. And they would be freedom from discrimination and violence, social inclusivity, and access to economic resources. And I want to take a moment here to talk a little bit about as a general, our population in general have been experiencing social isolation and in some kind of level, and as well as access to economic resources. This is compounding for those who historically experienced this already. And so and I'm not going to I'm not going to talk specifically about marginalized or racialized populations, but there are large portions of our population that experienced these prior to the pandemic. And there are reports from the United States that state that it really is a compounding complexity, in that those from racialized and marginalized populations experience the impact of the new social isolation in a greater manner than the general population due to their already existing experience with marginalization. So, how do we work with clients and the first part of this is actually talking about our clients in treatment. And we're going to talk about getting clients into care a little bit later. And, how do we work with the clients in front of us that are experiencing social isolation, that are experiencing impacted mental health, and what are we seeing? And I know from speaking to people in the field and from being in our centers that what we're actually seeing in our clients coming in is a higher level of complexity. And I don't have data looking at this. It's actually fairly early, and I'm not sure if we have more clients coming in with concurrent mental health, or those who have pre-existing mental health conditions that have been exaggerated or exacerbated by the condition of being in social isolation. I do know that that we're seeing a much higher level of complexity. And the other part that we're going to talk about a little bit is, coming into, and if I'm speaking about in-person programs, there's also the addition to having been in an isolated state, due to addiction, also due to COVID, and then coming into a community where you're with other people. And that actually is a little bit of kind of the second part of social isolation, is social resignation, and then the amount of fear or anxiety that we feel in reintegrating into social circles, which is, I think, for some of our clients going to be where we're going to want to be working with them as we're moving forward. And so social isolation, one of the lessons is that it should be a prominent focus of assessments. And what I mean by that is, we do a really excellent job in talking about and assessing isolation as a result of the use of substances. And historically, that's been kind of a central assessment of the level of substance use disorder is isolation as we drop away from relationships. And what I'm talking about in this circumstance is actually contextualizing when we're assessing our clients on how the social isolation happened and whether the social isolation came first, because we now have an experience in our society where this actually came first. And it wasn't for many of our clients, it actually may have been what drove the substance use instead of the other way around. And this has been true for some of our clients previously. Social craving as a psychological phenomenon in relapse prevention. And like I think of like the HALT model that we use, and that does a very good job of helping our clients learn how to manage a physiological phenomenon and have psychological and behavioral ways of reacting to it. And as we talked about, social craving actually feels a lot like hunger and it feels a lot like drug craving. And when we're working with our clients, actually talking about the fact that this is what we're doing. It, socialization, being part of a recovery community, connection and meaning is historically some of the founding pillars of what we do in addiction treatment. And we do it often in order to build connections, but talking about it as actually fulfilling a biological need that we have is going to be important going forward. Treating social isolation as trauma in its own right. And so, DBT and ACT are the two that come to my mind, and utilizing our DBT skills and our team's DBT skills when we're working with our clients, and looking at the experience that we've had of isolation during COVID has been traumatizing. It's been traumatizing on a community level. It's been traumatizing on a system level. And it's been traumatizing on an individual level. And there can be what that means is that we have clients who already had trauma coming in with multiple traumas, if we include this one as well. It also means that those clients that we had accessing our programs that were not presenting with acute trauma or even moderate trauma are now experiencing this as well. And so focusing some of our work in actually allowing our clients to kind of manage the trauma response from social isolation specifically, and kind of asking them and framing it, that this is actually where it's coming from. So in having the conversation about how did it feel to be alone during the pandemic, how did it feel to not be able to communicate with your loved ones, have you felt that feeling while you've been in treatment with us, have you felt that feeling while you're on the wait list? When you feel that feeling, what are we going to do about it? And treating it as is it its own event and its own very important event in mental health and addiction treatment and recovery as we go forward. And the other one, which we tend to lump these together, and that is the kind of isolating stay-at-home order effect, and then the trauma response and fear from the pandemic. And they actually are two different things. They happened at the same time, but for our mental health, they actually are two things that can currently happen that are distinct. And one of them is, all of a sudden in our communities, being in physical contact with other people became dangerous. And there was a virus that we didn't know how to protect ourselves from, particularly in the early days of COVID. And I'm thinking about the time of late March, early April of last year. And that is absolutely a traumatizing experience. And as we know, the cortisol response that we have learned to have to that can easily get triggered in other ways. And so what we are going to be seeing, what we are seeing with our clients is they've been very much sensitized to threatening experiences. And compounded by that is those who have experienced social isolation are actually specifically hypervigilant to social threats. And so rejection, any kind of slight that they feel from others. So treating that as and helping our clients develop, grounding techniques have been important in in treatment previously are going to be even more important going forward. And knowing to use them and having our clients use them in whatever way our clients best react and our staff best react. Using our post-acute withdrawal syndrome interventions for social resignation. And so what social resignation is that period that I am in now, and a lot of us are in now. And we've learned a lot of new words during COVID, and one of them was languishing. And I think that this is very closely related to that. But those who have been in a forced isolation for a period of time, after a while, we adapt to it. And the way that we're seeing people adapt to it is through resignation. Some of us have developed healthy coping skills. Some of our clients have developed some healthy coping skills, which we should encourage in a strength-based way. But also, slipping into resignation and hopelessness. And what seems to be the best approach for clients that are experiencing that, because it's a little more difficult to draw out, right? Like many of our clients already feel hopeless when they come in. And it's difficult to tell, and it's difficult for our clients to understand that where that hopelessness is coming from, and that it can be coming from multiple places. That we can have this feeling based on our adverse experiences from childhood, as well as our experience through the progression of use and addiction, as well as the experience of being socially isolated in some level for 16 months. And the things that are the interventions that are seem to be most effective for post-acute withdrawal syndrome seem to be most effective for this as well. And that's a normalizing of, this is an experience that we are in, and this is something, it's normal to feel this way. And most importantly, that it's not going to last forever. And what has been found is through socialization, this does dissipate fairly quickly if we're able to kind of move past it. And the other one is changing our messaging around alternative means of communication. So first, changing our messaging around alternative means of communication and the creation of virtual communities. And, in the media, in the way that we talk about it ourselves, in the way that we think about it ourselves. When I think about my thoughts on this being a virtual conference, even though I have been discussing how powerful virtual connection can be, I felt it to be something lesser and not quite as good. And we hear this message repeated a lot. And we hear it in things like Zoom fatigue, which absolutely is a thing, or that, next year we'll be in person, as if this experience is not quite the same. And it's not quite the same. And it's important that we do recognize that. But when we're talking with our teams, when we're developing materials, when we're speaking with our clients, it's different, it's not less than. And that these connections are real connections. And so when we're working with clients, having them kind of guiding them to describe what they're doing virtually with family, and actually I want to stop for a second. Hold on, I'm going to put this down. So I'm going to ask how, with social distancing, with the need to distancing, with not being able to have visitors and programs, how have people allowed their clients to connect with their families or to connect with the outside world? Mobile device. Oh,
Yeah, there were a few people talking there, Mike, and we got to remind them to unmute themselves.
Okay. So everybody unmute yourself when you go to talk. Can you unmute yourself? Oh, no. I thought this was going to be the session that didn't have any tech issues.
No. So what we could do, if they want to speak there, if they could put up their hand on their picture there, then you could hover over and you could ask them to unmute. They'll have that option. And I'll remute people if they get noisy, but we're okay to go with that. So I think
Okay.
Vinco's got his hand up there. You got
Yeah,
it?
hi.
There we go.
I'm from Vancouver here. We supplied our clients with tablets, and they all had access with Wi-Fi to connect with their family, to attend 12-step meetings
Yeah.
virtually. And yeah, that's how they were able to communicate. At one point, they were confined to the building. They couldn't even go outside for a short walk. So that seemed to help them quite a bit.
Mhm. Jennifer?
Hi. In Calgary, I'm going to say we were blessed because we were still able to allow family. It went from 4 to 2 people. It had to be immediate family, but they were allowed to visit. We had one of our group rooms that has an outside door, so they could come in that way, and we just followed all the protocols so we could keep that connection that way. And there was still a handful of 12-step meetings that were open that were following protocols. So we really were able to continue to have that connection that way, and everything else, using social media platforms. So that was really great for us.
That's great. Jim?
Oh, there. Yeah. Hi, Jim. Yeah, thank you. Yeah, we increased our daily use, allowing them their use of, or our use or their use of our electronics. So an hour and a half a day of them being able to FaceTime, phone, Zoom,
Mhm.
as well as additional 12-step meetings in evenings was important. We weren't allowed to have anybody on site.
Yeah. Thank you. Don? Oh, you're on mute.
And Don, can you put up your hand so I could see where you are, so I could hit the right button on me? Yeah, thanks. Oh, there you are. Oh, I should have knew you, man. Hang on. There you go.
Okay, I'm there. You're all hearing me now?
We're hearing you.
We run a recovery home in Cambridge of up to 10 men. Right now we have 8 men at the home. We always leave a couple of beds open for waiting for treatment. However, what we had to do in the beginning of the pandemic is went by the guidelines of Ontario, which was social isolate. So we bought computers for the men to use to communicate with their families, to do the 12-step meetings, etc., stuff like that. And also they have always have had access to the computer, to another computer in the basement. So this wasn't unusual for them. And the phone, they've had the phone all the time because it's a long-term recovery home. It's after treatment, right?
Mhm.
So, but the social isolation was really difficult with a lot of the men.
Yeah.
Because they couldn't, their families were just starting to get back with their families because they've been in recovery for a long period of time. So we decided that if they wanted to meet a family member, they could come to the house, but be about 20 feet apart and talk that way with masks on. But they couldn't go out and do overnight visits or anything like that. And that seemed to help a lot, just for the client himself, plus the family members. It worked. It was a win-win both ways. You know what I'm saying? But I understand when you're in a treatment center for 3 or 4 weeks or 6 weeks, it's a lot different. You guys must have had a harder time dealing with it than we did. So, congratulations goes out to all of us, because it was sort of like play as you go, eh? What do? And then you're making up things in your head, eh?
Mhm.
how do we get them? Okay, thanks.
Thank you. Jennifer.
So, yeah, I do work in a residential treatment facility that runs for 4 weeks. And it was terrible because the first 2, they had to be in isolation by themselves in their own rooms. At first, they weren't even gonna let them go outside at all for a smoke, for a walk, nothing. And, I brought up even convicted criminals on death row get an hour outside a day
Mhm.
because it's that hard for them. So we did the same thing. We bought, I don't know, 25 iPads. We gave them to them. We conducted group like that. They went to meetings like that. They were allowed to watch movies and whatever they wanted to do in their spare time. But it takes a toll, not just on the clients, but the staff too. It's really stressful to make sure your client has their needs met while they're in isolation.
Mhm.
And there's only a few staff members, right? So, but one thing I have noticed is I've seen people getting sober online
Yeah.
and staying sober.
Yeah.
So far, so good.
Yeah.
Thanks.
Thank you. Julie?
Hi, my name is Julie and I'm a NADAP worker in Thunder Bay and can't see you because this is, all right. I couldn't see you. There was something in front of your face. My agency was very supportive. We have a shelter where they were, yes, they were not allowed to go out for 14 days. They had to self-isolate themselves. But they had all the technologies and all of the ways to contact the outside with technologies. When it comes to my client, though, it was difficult because a lot of my clients are transient, so and they don't have electronic. And if we give them electronic, they're gonna pound that to get what they need to live. So it was very difficult at the beginning to keep the contact with them and stuff, but we posted everywhere on Facebooks with a new phone numbers where they can contact me directly. So I had some of the contact like that with this, but the pandemic has been very difficult for us
Mhm.
to deal with clients, especially me, because like I said, they don't keep electronic for very long. But with the advertisement and everything, they still kept contact. So it was really, but it's still difficult. They want to come face to face.
Yeah.
That's what they do. So
Thank you.
thanks.
Hussein? Okay. So why don't we kind of go back? If you do have additional comments, type them in the chat. There's quite a few of them there. I haven't been able to read them, but we're going to look back because there was a couple of really good comments there towards the end of the presentation. But the interesting thing is, these solutions, like, are these solutions that we will only use during COVID? Or are these solutions that we can use in order to improve the connectivity in our programs as we go forward? And that's what a lot of like my reevaluation, we did the same thing. We gave, previously our clients didn't have their phones all the time. And our thought was, we are trying to have our clients just focus on treatment. And it was a little paradoxical in that when we started to give them access to be able to Zoom with their family once a day, they actually, many of them seem to be able to better focus on treatment. And I'm thinking about the one treatment center of ours that I was spending a lot of time at, where they wanted to visit with their children. And it was every 4 o'clock, they would do a Zoom meeting with their children. And we had that time out, and it just kind of actually increased the structure of the treatment program instead of taking away from it, which was actually a lesson for myself. And okay, but changing our messaging. So a friend of mine, actually, I asked them the other day what they were doing after work, and they said, well, at 6 o'clock, I'm doing happy hour. And I said, like, my first question was, are you going to a bar in 1985? And they said, well, no, it's happy hour. Me and all my friends have an open Zoom meeting at 5 o'clock every day, and we call it happy hour. And as I was driving, I was thinking, like, what a wonderful way to reinforce the connection that's happening by calling it happy hour. Like, the language that we use is really important. And in our programs, for a very long time, we've been so good at this, right? Like, you hear people out of inpatient treatment talk about the house that they were in, or the center that they were in, or the community that they were in. And a lot of that comes from overt language from our staff. And we're able to do that in person, outpatient, and also when we're working individually with clients and in sober living houses and supportive living. And if we were to leverage that kind of intentional language in talking about connecting through virtual, it could be a little bit less of something that we're doing just because it's COVID, and another tool that we have in our toolbox going forward. And, you know, our clients kind of show us our clients show us some of the things that we should adopt. When we launched our outpatient program, our clients created a WhatsApp group. And I learned 2 lessons from that. One, they really wanted community, and the power of a group messaging application to contribute to community is immense. They benefited from it. They loved it. They mentioned it all the time. The other thing I learned was it needs to be moderated, because very quickly it you know, just like the social learning that goes on outside of group, it can be positive or negative. And, you know, we need to find ways that we nudge it to the recovery as much as possible, either by moderating it and that has, you know, we can use this in our programs going forward. I think about an in-person treatment center that has like a group chat like that, even after COVID, where people can share things about what's going on in program and connect with their alumni afterwards. Including strategies to manage anxiety around rejoining society. There was a study done by the American Psychological Association that said 49% of Americans were anxious about rejoining society in some way. So we've now kind of gone through the acute social isolation, and we're at a place where our social level of being is lower. And when we go to increase that, it can cause anxiety, even in those of us that have not had anxiety about it before. And it actually seems distinct from fear of the virus, because in a lot of these areas, the virus is actually not circulating that widely. And it actually seems to be having to socialize again when we haven't been socializing in such a way for quite a while. And it made me think a little bit about, you know, how many of our clients who have struggled in early recovery in the past have had this on a lower level, and how can we build this into our recovery, post-treatment recovery planning in order to support those clients. And, you know, using acceptance and commitment therapy seems like one of the ways that could do that, or whatever, you know, therapeutic modality that your team uses and feels most comfortable with, to normalize that. And to be able to say, you know, this is something that's normal. You're supposed to feel anxious when you're starting to socialize with people again. And it goes away fairly quickly, but let's talk about how you can manage that. Let's do a little grounding. Let's do a little tapping. Let's do some kind of self-care before we do so. So the next part that I'm going to talk about is actually, you know, when we look at what differentiates problem use and abuse from addiction, And, the main ones that come to mind in most models are continuation despite consequences, which commonly include problems in social and familial relationships, often the end of those relationships, social isolation, poor work, school performance, and or job loss of interest in drug-related activities, preoccupation with substances, using a risky situation, using alone. There's a large portion of our population. We talked about the fact that a lot of our society is drinking more heavily or using more heavily than they did in the past. And those who have been laid off, who are not working, or some who have been working from home, are actually now experiencing this not as a progression of substance use, but kind of backwards. So they've ended up in a situation where they are experiencing a lot of these things, and their use is starting to rise in order to account for it and to fill their time and to deal with the mental health that they're feeling. And that's a little different from models that we've used in the past. And there are studies on this. There's a very famous study, the Robin study on returning Vietnam veterans after the war, where she found that around 40% had used heroin while they were in country, and that a very small percentage of them continued to use heroin when they came back. However, those that did and were at most risk were those who had had some substance use in the past. And those who had some substance use in the past and did continue addictively started to inject for the first time. Injection was actually very low during the Vietnam War, and they experienced fairly high consequences and a fairly high level of acuity of substance use disorder. And this is actually similar to late onset alcoholism in many ways. The clients that we're seeing right now, or the part of our population that's off work and possibly using more heavily right now. And so late onset addiction seems closely related to loss of social connections, isolation, loss of purpose, related to retirement, boredom, financial insecurity, and depression. And I'm wondering if we are seeing these clients in our programs yet. And we're going to talk about that in a minute, because I don't know that we actually know to the rate that this is happening and how much it will continue after social isolation is no longer as necessary as it is right now, and when they will start to look for help. So the good news about this is those with late onset alcoholism are often more amenable to treatment and tend to have better results, and lower intensity treatment options are particularly effective with them. The most important thing is receiving treatment early. And are we seeing these clients on our wait lists yet? And I'm sure that we're seeing some of them. However, generally our clients start to seek help when their use starts to impact on their life, not the other way around. And so my thinking is that we may be seeing these clients going forward as people start to go back to work, and as that fear and that anxiety of being socially isolated and having to reintegrate starts to come up. And that's a little frightening for me, because as we talked, our wait lists are already quite a bit longer due to distancing than they were. And there may be a population that may be accessing our treatment, our services in the future that isn't quite yet. And we don't know any of this yet. However, it seems that virtual models may be quite effective in assisting these clients, because the lower thresholds and the similarities to late onset alcoholism. The thing is, how can we assess whether this happened? And many of the assessment tools we use right now won't tell us that story. We talk about consequences of use, and we talk quite a bit about progression of use, but we don't contextualize really to that level and make it kind of a priority decision-making and matching to level of care. And the other part of connection, the other part of utilizing things like WhatsApp groups is the physical structures of many of our programs are built upon trying to bring people together. Like early in the pandemic, I thought, like, if I was to design a more difficult environment for this situation, I probably couldn't come up with one. than what we have in our centers. And the very reason is because we're trying to assist our clients in connections and developing community and being able to share experiences and start those skills that they haven't been using. And as we move forward and we start planning future physical spaces with the experience of the pandemic and the lessons of the pandemic in mind, how do we ensure that we still have that level of connection, even if we are physically separating our clients a little bit more than we used to? And I'm thinking about things like single bedrooms and single washrooms and dorm style, which have been talked about in planning for future pandemics. And in making should we experience this again the next time easier, how do we still keep our community in our centers intact? And many of these technological kind of innovations may be some of the ways to do that. And virtual models of care have been able to rapidly increase capacity in this system. They absolutely have been. And I'm going to talk about our experience. And future planning, I shouldn't have put, but have been limited, but our future planning might want to look at the way that we use virtual care and the way that we connect care a little differently. So in April of last year, we, like everyone here, we actually paused our admissions for a short period of time. And then when we restarted our admissions, we recognized that we had lost about 50% of our capacity and already had a significant amount of people on the wait list. And how were we going to be able to help these clients if we're not going to be able to get them through treatment, at least in a timely manner? So we decided to launch a virtual outpatient program, which prior to this, when people had spoken about virtual care, I had said, yeah, it's probably good, but not nearly as good as sitting down with somebody. And I wasn't really a fan of it. And with outpatient care as well, my opinion was it wasn't what our organization did. We do inpatient treatment. The experts in outpatient should do outpatient. And so what we did was we looked at developing a way that we could decide who needed to get into treatment right away. And we did a literature review and took the existing validated treatment matching models, particularly ASIM and LOCUS. And what we found was the threshold was actually far too high to help us get down to the number that we needed to be in order to meet the limited capacity we had in treatment. They just were too high, and I'll show the results of that in a minute. So what we did was we developed some criteria that really was a client who was at the risk of loss of life, loss of enduring functioning to themselves or somebody under their care within 90 days, and evidenced by an objectively measured event having happened in 90 days that would lead us to believe that. So these are really the most highly acutely at-risk clients. And our access center, contacted everybody on our wait list, and we steered those who did not meet criteria into our outpatient program, and we steered those who did into our inpatient program. And a few of the things that we found, the first was in the initial run, when we were looking at those that we had put on pause or were to come in very shortly, we did 145 risk of harm assessments. 86 of those clients met that higher level, that higher threshold. So 59% of our clients that were on our wait list were actually at risk of enduring loss of life or functioning within 90 days. So one of the things that told me was, in the model that we're using right now, those that need inpatient treatment seem to be getting into inpatient treatment. There seems to be few people coming into inpatient that do not need that level of care. And I would imagine the same would be true for intensive outpatient. So the model that we're using in the treatment matching that we're doing right now is actually really effective. However, we learned a few things from this. And all of these clients had approached us for inpatient treatment, and we did some groups along the same lines as this WhatsApp group that these clients formed. They actually formed an alumni meeting very quickly after our first clients went through. So in our treatment centers, each of our centers has an alumni committee, and they do alumni meetings. And this is also has been one of the real benefits through the pandemic has been that they do sessions, an alumni session where they come back and they talk about the treatment center with the clients who are in treatment right now. And the outpatient, I think it was like, it's a 6-week program. And I think within 8 weeks, they had an alumni meeting running. And in those alumni meetings, we talked to everybody who had went through, and they had chance to talk about what their impact was. And we also used it's called the Virtual Care Evaluation Survey from CAMH that they developed really quickly to measure virtual care. And we used that with all of our clients as well to get information. And this is what we learned from them. So I actually did our first admission to our outpatient program. And the first admission was actually somebody who had been through program before, and I had actually worked with. And he had had a little bit of a fairly scary relapse very quickly after being in treatment with us, and had been using and wanted to get back into treatment. And he was in that first cohort when we started talking to our clients and seeing what their feelings about the program were, and how they felt that it helped them. And he actually said that having been in inpatient treatment made this a better level of care for him. And the way that he described it was because he had had a real experience within the last year of being in program that he could recall, and didn't feel that he needed to have gone through inpatient again, because he was able to take that benefit of outpatient programming and combine it with the benefit that he had from inpatient programming. So he had the experience of a recovery community, he had the experience of being in the safe place, and he was able to get the support of our outpatient team and the group sessions while he was learning in his real life in real time. And this is different than most treatment of care matching systems. Normally, having gone through treatment and not having success in treatment actually puts you at a higher level of care. The combination of intensive program sessions and self-management was identified as particularly beneficial. And clients with social anxiety, trauma, and borderline personality disorder reported that they found the virtual format more comfortable and supportive than in person. This is a very small group. However, they did describe that they felt safer in that they were in their own home. A number of them said that they had been in inpatient treatment before and had really struggled to engage in group, and in virtual, they were able to engage at a much higher rate. And for them, that was really the most important thing. And that was what had limited them in inpatient treatment. And, borderline personality disorder and the effect of outpatient treatment is, I think, something that deserves some research as we go forward. Because it can be very difficult to be in an inpatient or an in-person outpatient program with borderline personality disorder. And because we have distress that it can be triggered by our relationships with others and by our impressions of our relationships with others, particularly when we don't feel stable with those relationships. And then the clients come into a house where they need to meet 15 to 25 new clients and 8 new counselors. And it really is an overwhelming experience for them. And I think that there's a really dramatic opportunity for us to help these clients at a higher rate through virtual care. Clients with depression, anhedonia, and stimulant-related post-acute withdrawal seem to struggle with attendance and engagement. And that makes a lot of sense in that these clients in inpatient programs are really assisted by the structure and by being able to be up and kind of follow the structure and the immediate supports. Supportive client community developed despite absence of in-person contact, and we talked about that, and it really did really quickly happen. And consistent housing with privacy for the session, regardless of the arrangement, seems a critical criteria. And this was actually interesting because it wasn't what I thought it needed to be. I thought you need a place where you can be private and sit down and be comfortable. And I was thinking like really stable housing. And what it actually turned out, it just consistent housing seems to be the important part. We had some clients who actually did the sessions from their cars. We had some clients who had young children at home and did the session from their phone in their room. so that they could have privacy in order to be able to do that. But you didn't seem to need kind of the level of privacy that I thought, as long as you could have the consistent housing. Those who came through and did not have consistent housing, we almost without fail ended up putting them into our inpatient program after a little while because they really struggled. So what we learned is the dimensions of existing treatment matching models don't seem to correlate to virtual versus in-person treatment matching. And really it has been a lesson for us. And, we had never offered multiple levels of care before, and we are keeping our outpatient program going. And so we have adopted Locus now that we have some more capacity as our treatment matching methodology. However, we actually have to do, that clinical judgment when we're doing them. And it seems to be the same clinical judgment for all clients, which seems to tell me that we need to reevaluate the actual assessment and level of matching system and put priority on housing and take some of it away. And I'm not entirely sure what it looks like because this is very early, but it does seem that there needs to be a need there in order to be able to get clients into treatments that will be most effective for them. And the surprise for me was, I thought what we were going to learn from the outpatient program was that it was almost as good of, or at least we were able to do some programming. And the surprise was this was better for me, coming to us from so many clients. And when we're looking at developing a system going forward, this is my blue sky. If we get some capacity and we're able to make some changes and really help some people, how can we do that in a different way from this experience? And one of the things that we've started to learn is that the relative inherent strengths and limitations of inpatient treatment, in-person, community-based programs, and virtual programming are all complementary to each other. So combining them in modular care models is one way that we could not only provide higher levels of care, but also with less demand on capacity. And so, for instance, doing a virtual outpatient program before doing an in-person outpatient program, one of the strengths of the virtual outpatient program is it takes less motivational investment each day to get to session. And for clients who are able to do that, they can build self-efficacy while they're doing that in order to be able to get into the in-person outpatient program afterwards, and then do what is really strong in that program and then move on to a continuing care model. Our other options can be doing a virtual outpatient program before doing an inpatient program. And this can be for clients who have had no experience with recovery in any way, and they are able to kind of learn how a group works and make a more efficient use of the inpatient period of time, and then move on to continuing care. Or the opposite, where you do an inpatient and then a virtual outpatient. Because one of the challenges of doing inpatient addiction treatment is the sudden transition back to real life. And continuing care can help that. But if we can put another very high level of an intensive outpatient program afterwards, coming down to a continuing care, and the way that this can help us with our capacity is these can be shorter programs, because really what we're looking at is a longer program. And these models came out of us thinking about doing this in one organization. However, this can also work across organizations if we're able to get to a place where we can seamlessly transition people. But the adaptation that would seem to be made there, because the benefit of this is that you're moving with some of the same clients and that you're experiencing the same community as you go through. And if we're going from one organization to another, one of the ways to do that is to do kind of crossover services. So if you are in your inpatient treatment program, you do some sessions virtually while you're in your outpatient treatment program, inpatient with your inpatient addiction counselors. And then when you come into inpatient, you continue to do outpatient groups with your outpatient virtually. So is there any questions about that so far? I want to see everybody's face again. I get kind of lost and bored when I'm just talking to my own presentation. Do these make sense? Does anybody have thoughts on these? Because there we go, Jennifer.
Mute. Hi. I agree with everything that you said. I just wanted to share that at our facility, we've been using we've been using GoToMeeting. I want to say it's been about 5 years for a family healing program. So there was already a familiarity with it. So when COVID, dropped on our doorstep, the transition to needing to use that within our groups was a little bit smoother because there was some familiarity with it already. So being able to connect, there was a couple of different things that happened for people that were staying in, with us, living with us. Some of them, the fear that they had, but they had supports in community, so they wanted to transition back to community as COVID was ramping up. We just transitioned them back, and then they just came online with us, so they were still able to complete program. And then for other people that weren't able to come in, because at one point we weren't allowed to take anyone in, we had a lot of people online. I had a lot of web cameras going on in all the counselors' group rooms to make it happen, but we were able to continue providing program the whole time. So, and it's something that we will continue to use, even if we had someone that needed to be isolated, because we had, access to, if it was iPad or whatever it was, if the guy had his own phone, then he just followed group up in his room.
Yeah.
So it's fantastic. And I would, it's something, because we've already been using it, we will continue to use it, and it reaches people. We've had people in the States, in Europe, all over the place take our programming because their family may not, be in Alberta. So that's why we actually started it so many years ago. So I'm a big fan of it. And to be able to, the other part was, if there was a counselor that was needed to isolate at home for 14 days, but they weren't feeling ill in any way, they just maybe had been in contact or something happened, they were running group from home. We just set up the camera, in the group room, and we worked it all out. And it's been fantastic. So all kinds of uses for it. So I'm a big fan of all of it.
Yeah. When we first launched it, we actually staffed it with, we had split our inpatient teams into 2 cohorts. And so it was our inpatient counselors who were running at first the outpatient program. There was definitely a learning curve. I wish that we had it existing beforehand. But at the same time, it like, what really amazes me is that if you put counselors with clients, they'll connect. It just happens, right? And it happens in a fairly organic way, and it happens in a way that you can build on. And we've been developing the outpatient program continually and are ready to ramp the size of it up. We're going to be continuing it as well. But the novel ways of using it, like having somebody do a session from their room, or having people do sessions and my thought is having people do sessions in multiple programs, having somebody in our inpatient program who's doing a seeking safety group virtually with another organization, and maybe doing a children's program in their own culture, and something that is culturally appropriate. And I think that we're very early in realizing really how much we can leverage this, and how much impact we can have for our clients. Marion, you're on mute. The phrase of 2020.
Thank you. I'm curious if you found income to be restrictive. A lot of people that we have on OW can't afford the internet. And so if they needed internet connections, if there was any subsidies available, or what you did, or if you even encountered that.
We did. And that's the fundamental challenge to virtual care, is access to technology and access to Wi-Fi. And because even if you can get technology, the Wi-Fi can be expensive, and just the data can be expensive. And many of our clients don't have that. And, what we did for the most part was transition them into inpatient care. That's
Okay.
kind of the solution that we could come up with. It's not a long-term solution. If we're talking about, system level changes along these lines, we do need to come up with a solution that's equitable and fair for sure.
Okay, thank you.
David.
Hey, David, can you raise your hand so I can find
Yeah,
us?
there it's back. Sorry.
Okay.
Thank you. Yeah, my question was, Michael, when you talked earlier about the importance of the language that's being used, and you referred to how kind of outwardly counselors refer to, well, like the house, right? And I think that's very important when you're using or encouraging people to use language around virtual programming. Is there something that you've found that kind of takes the replacement of that? That kind of says, oh, well, you're going to go to the whatever, or they're involved in the whatever, that still has that sense of community, but clearly isn't the house. Because I do virtual outpatient stuff myself, and I thought that's got to be something to pick your brain about.
Yeah, it seems to be the group, and talking about the community, it seems to be the best way. I mean, you can talk about the virtual space, but really when we talk about the house and inpatient, what we're referring to is the community, and it's just the house is a really good, easy to grasp on symbol for that. So I believe what we've been using most often is this group, this community, this fellowship, whatever we'd like to call it. Yeah.
Right. Okay. No, thanks.
You're welcome. Okay. So I next have, this actually leads into some questions as well. And because the last part that I wanted to talk about is what about us and what about our teams? And because, the American Psychological Association report, it had a lot of really good numbers, and it was a very specific report that just talked about, they called it stress in America. And they identified 1 in 4 essential workers have been diagnosed with a mental health condition and during the pandemic. And the other number was 85% of essential workers reported they could have used more emotional support than they received. And I don't think that is a very broad sample size. And I don't know if it would be the same for us in our field, but I do worry about our teams all the way through, from those who are delivering care to our leadership to, we have a number of really prominent struggles, and some of it is, what everyone's experiencing, and some of it is the limitations that have been put on us by distancing in order to be able to help people. Our teams are so passionate that it can be difficult when that is kind of constantly made hard. And I've heard so many amazing things that people are doing with their teams, and I wonder if anybody would share some of the things that have been the most impactful to bring their teams together or reinforce community with your team during the pandemic. Jim?
Thanks. I just got to say, I'm really enjoying this, and I'm really enjoying your energy. I was in Renaissance in '86 and changed my life and started me on a good path. So I'm having a lot of good feelings here. At the Edgewood Treatment Center in Nanaimo, we've been encouraging staff-driven 12-step recovery Dharma meetings and some other associated stuff. So there are a lot of us that are practicing different programs from a variety of places, and so we're bringing it inside and encouraging that. It seems to really help us, despite the fact it's on site.
Yeah. Vinko? Try again.
There you go. think of anything specific. Like we all supported each other, as teammates and coworkers. But what uplifted everybody during the peak of the pandemic, it was a nice increase in pay that the employer gave us. It was a pretty good incentive and uplifting.
Yeah.
Money
That would,
talks.
that would definitely be a really good way to take care of staff. Yeah. Anyone else? Well, I can share that what we did was we did a number of virtual meetings with our teams, and during the early part of the pandemic, this was actually sharing information, and it was just keeping everybody informed. And then we, as the pandemic went on, tried to make it as fun as possible, with more or less success depending on the meeting. And the ones that we really seem to have really good traction with our overall team were when we actually normalized kind of COVID and the experience of being in COVID, and having conversations about, like, what was your COVID hobby? Like, what did you pick up while you were kind of in lockdown, things like that. Robin?
Something that our team did, our management supplied food. And by that, I mean, we had a luncheon, because we're so used to living together as staff, because we run a residential program. So when COVID hit, everybody went home, and we worked from home. And our community went into emergency isolation for a bit. So we were really kind of disconnected from each other in a way that we weren't expecting. And food always brings us together, because we are collective in that sense. So our management prepared and arranged for food that as staff, we could do a drive-by and pick up our lunch and go back and have a virtual team meeting and still have that connection and gather and have a meal together. And that was really important to keep that connection, and to just kind of bring it back to we're a family, we're human. And, we share our family life, our work life, and our community life, because we were all connected in that way. So that was pretty neat, I thought.
Yeah, I love that. And so I want to leave room for questions. We have 10 minutes left in the session. So does anybody have questions kind of in general?
I have more of a comment there for you, Mike, if I may.
Yeah, sure.
Sure, yeah. I hide behind the picture there in the background there. Anyways, I want to thank everybody for being very good for muting and unmuting yourself. But one of the things there I know from referring people to the places where you're working in residential there, but my experience when referring people to Renaissance there, when you had for the outpatient, the video thing, it actually worked really well for some of my clients there. So I'm gonna, I'm just throwing you a great shout out there. They've done very well. And because one of the things when I get somebody into a residential setting, the big, what can I do? Can I bring my C-phone in? Can I do this? Can I do that? And it really was a barrier in the beginning from people find their way into the homes there, but it took a lot of work. And, we had to take out our bag of tricks to get, usually we could drag a client in by the ear. Sometimes you really want to, but they had every excuse. And this was one of the excuses there. But I think all the treatment facilities under the circumstances managed it very well. So just a shout out there for you there, Mike, and anybody else that wants to be muted or something like that, give me a wave of the hand. I can make sure that software works good there, and everybody else has the last say, not me.
Thank you, Tom. Yeah, that was actually I've been amazed with how much work can be done virtually with clients. I really have. It really surprised me, and that's where this presentation is, how can we continue to use this in novel ways, because it really did impress me. Everybody's saying goodbye to me in the chat. Does that mean it's over? Aren't I supposed to pick that? Okay.
No, it's up to you, Mike. Where do you want to go from here there? I give you a 2-minute warning before the
Well, I think
stopper boots everybody out, but I think there's a lot of people. Maybe don't be shy. Shout out if you need to.
I think the group made the decision. They've been kind of waving and thanking me in the chat. So I want to thank everybody for joining us for this. This has been great, and I'll see you all soon.
Okay, thanks very much there, Mike, and I'll end it there. Big shout out for you.